in the 3D Ingenuity system. And we'll have low-lid blepharoplasties, and the phaco's will be with the different types of IOLs. And we are, regarding the pediatric cataract, these girls, we have selected 2 patients and both came out to be COVID positive. So the pediatric cataract will not have. So total, we have lined up 8 cases. So can we start now, madam? Madam, should we start? We can't hear.
Yes, please start. Please start.
Okay. So before we start, we would like to have the timeout. Dr. Vatsalya is here with me. Dr. Vatsalya, please start the timeout.
Patient is a 68-year-old female. The operating eye is the right. Diagnosis is immature senile cataract nuclear sclerosis grade 3 with a nasal pterygium. As per her biometry, she is a high hyperope with emmetropic IOL power of 27 diopters.
So this patient is very high hyperope, and her axial length is only 20.3. So we need a high IOL, which is 27. But what to do in Northeast, most of the cases we get this type of cases only, we get quite high hyperope cases. So we have kept some challenging cases. I just want you all to share your experience also with me, how to manage this hyperope, especially on a topical anesthesia. So I have just given the viscoelastic. Here I have given the Provisc. I prefer Provisc because it not only gives a good maintenance of the anterior chamber, but also it coats the endothelium very well. So I'm starting my capsular axis as usual. I usually prefer in an anti-clockwise direction, as you can see here.
So this is being done under HPMC, Dr. Kasturi, or under?
Yes, yes. This is Provisc from the Alcon group.
Okay, okay.
And this is the patient is otherwise having a good NS3 plus PSC with a good red glow, and she has pterygium also. So I have just completed my rexis. Is it seen?
Yes,
this is approximately a 5 millimeter rexis. And now I always warn that when we do the incision, the most important is the inner lip. I usually don't like when the inner lip has a dent. I usually prefer when the inner lip is exactly straight, as you can see here. So this is the inner lip of the incision. Is it visible?
Yes, yes, very well.
Yes. So I just completed the first 2 steps of the surgery. Now I'll go for the hydrodissection. Trying to do a little bit of hydrodelineation. Like this, many of the residents are also observing us. So this is the typical golden ring which we see. That is the separation of the epinucleus from the nucleus. So I usually do not rotate, because if you have such a good ring, I feel that the nucleus, but let me try before it. Rotation for the beginners, it is very important. So I'm using a Centurion system, which I usually prefer for most of my cases. Usually we in our institute, most of us use only the Centurion. And this is what is called the, I'm trying to go for the, though it has got a very good glow, but it's not a very soft cataract too.
Kasturi, you did say that you get a lot of hyperopes in your part of
Yes,
part of the country.
Yeah, usually I see that most of the cases are usually hyperope, like we see, maybe because of the small sized eye. But today I'm also keeping a very high myope if the time permits. Am I centered or not? If the time permits, I'll also do a very high hyperope. He is approximately having a refractive error -16.
Okay. So perfectly centered, and Dr. Rajesh Sinha, Treasurer of the All India Ophthalmological Society, has also joined us as a
Dr.
panel.
Kasturi, good afternoon. Very nice. I'm seeing the surgery very
Yeah. No, it's a
quick
pleasure
and
to have you here. And my fellows always speak so high about you and Namrata madam. Like
so
I'm
nice.
getting nervous operating in front of you all.
No, the way you are
Oh,
doing,
no.
it's wonderful. Wonderful demonstration.
Like I always feel, though me basically an oculoplastic surgeon, I always feel that every cataract surgeon should know some amount of the adnexal surgery also, so then we can give a holistic treatment. I just
True,
finished
true.
my lens, and because the next patient, blepharoplasty patient that I'll be doing, she also has a very advanced cataract. So like this is, I just finished my lens and now I'm going for my cortical aspiration. When I do a flex, I prefer bimanual. But when I do a non-flex, because in the flex, the cortex becomes very sticky. So I prefer bimanual, but when it is a non-flex routine conventional phaco, I usually prefer a normal coaxial aspiration of the cortical matter.
Yes, it's a very nice way of doing and very quick and very fast it comes out and you can aspirate it very well. In flax,
Yo,
the sub-incisional one gets a bit stuck to the capsule, so bimanual helps in that.
one thing, I don't know why the Rexis has given a bit way. Let's see.
So Kasturi, you are one of the few surgeons who are oculoplasty surgeon and also do aesthetic surgery and also do cataract surgery.
And not just do very quick and very beautiful surgery.
Yes, flat. So I'm taking this panoptics, and I prefer, she's a 70 years, 68 plus. So nearing 70 for the elderly. For the elderly people, I usually prefer a panoptics, and which gives a trifocal vision. Advantage is that this lens, which is a refracted diffractive IOL, it has a wide landing curve. So the defocus curve is wider. So
Yeah.
even if we don't, that is one advantage. So even if you don't get a very accurate lens, especially in a very high myope or a high hyperope, when they want a near vision, I prefer panoptics more than the VVT or the other new lenses that have come here. Can you see there is a small extension over here? I don't know. Kaise ho gaya? So I have just
That was a very-
completed. Yeah. I just completed my surgery and she has a pterygium out here. And later, and after me, Dr. M.J. Burman will be doing a small vitrectomy. But one thing what I want to insist everyone that once we give a viscoelastic, no, we should always wash behind the IOL. Cornea to clean kariye.
Did you have hydrated the wound, main wound as well, and then you have gone with the IA?
I usually do that. I usually hydrate, tighten up, and then I wash it and complete it.
Okay.
So with this,
maybe
I
while
finished
removing the
my,
IA probe, the chamber will be still formed because of the tight wound, right?
yes. So this is done and completed my first surgery. And now we'll go to the next OR. Dr. M.J. Burman is starting the vitrectomy surgery. In the meantime, if there are any questions, I can take up the questions.
So Kasturi, what about the pterygium? What do you plan to do with the pterygium?
If this would not have been a live surgery, I would have done the pterygium because of the paucity of time. So we are planning her and we'll take up on a later date. And this is not a very advanced pterygium. It is not
Yes.
coming near to the thing, what visual axis.
Almost like a
Okay.
atrophic pterygium. Yeah.
Yeah. What's the keratometry in this eye?
Pardon?
What's the keratometry in this eye? Any
Um,
astigmatism that
yeah.
it is causing, because it's a very small one. So
Yeah, it's a very, I think one X is 39.5 and the other is 40.2 or something like that.
so it's
a
nothing
very,
actually. So,
It's a very flat cornea.
yeah.
And I usually prefer, like, in case there is some I usually give some of the viscoelastic. And after giving this viscoelastic, till date, I don't have any case of fibrinous uveitis also. I don't know. Maybe there may be some micro leak or something. So, very nice. So, we are going to the next surgery now, okay?
Okay.
Oh, তথাপি দিলো।
Can we just have a little bit details about the vitrectomy surgery that we are going to see now?
Shasham, let us speak of the history of the patient.
A very good evening to everybody. The next case that we are going to see is a 66-year-old female who came with the complaint of diminution of vision in the right eye since 14 days. On visual acuity assessment, her vision was counting fingers close to face in the right eye, which was not improving on pinhole examination. And for the left eye, it was 618, which improved to 66 with correction. She was a non-diabetic and a non-hypertensive patient. Rest of the anterior segment findings for her were within normal limits. Slight early cataractous changes were noted, and the IOP taken by non-contact tonometry were 15 and 17. On fundus examination, the right eye fundus showed vitreous hemorrhage, whereas the left eye fundus was within normal limits. The patient was advised to undergo ultrasound B scan for the right eye as well as visually evoked potential. The investigation reports revealed that the right eye ultrasound showed vitreous echos as well as subhyaloid echos. VP was subnormal for this patient. On clinical report review, we had given the patient the options for observation, intravitreal anti-VEGF injection, and surgery. The patient opted for surgery. So now we will be seeing the vitrectomy surgery for this patient being performed by Dr. Manav Jyoti Burman, sir.
Dr. Rajesh, Dr. Namrata, I would like to introduce Dr. Manav Jyoti Burman. Dr. Manav Jyoti Burman heads the department of our vitreoretina services and also heads the department of ocular oncology. So he had done his fellowship at Shankara Netral at Chennai, and then he had done his oncology fellowship from Dr. Shields and also from Dr. Finger. So he has been with us since 2000. So he has been practicing for the last 22 years. So he'll be starting and he's using the Ingenuity system with a heads up, like what the Elcon guys say. So over to Mano, please.
Good afternoon, Namaskar, Madam and Dr. Rajesh. So I'm going to do a vitrectomy. It is
Good afternoon. Your voice is a little low. Can the audio people increase the audio of?
Yeah, is it okay now?
Yeah, it's okay now.
Better.
So it is I hope it is a plain vitrectomy because the history is only 14 days. And it is mainly because of time constraint, we are keeping it for mainly for the beginners. Okay. So I'm going to do it with a 27 gauge vitrectomy using a constellation vitrectomy system and a Ingenuity viewing system. So thus I'm going to do the 3-port. So as it is a phakic case, I am doing at 3.5 millimeter to 4 millimeter distance.
What's the cause of this vitreous hemorrhage subhyaloid? Is it vasculitis?
It is not a diabetic patient, and I hope it is a case of maybe a vascular occlusion or maybe vasculitis also. So I'm using the valve cannula here.
Can we make the light a little brighter? Yeah, now it is better because otherwise it was coming out to be dark. No, no, the other way was better. This
Yeah.
is a little dark. So can we make the light a little better or brighter?
Yeah. Can you send your light? The previous one, yeah. No, reverse the image.
Previous one, the previous one, yeah.
Yeah. So I'm going to the vitreous cavity. I'm go towards the center of the vitreous cavity. So to save the lens. So so the parameter in the machine, I am keeping a cut rate 10,000 with a vacuum of 600. Go to the posterior.
So which machine you are using?
It's a constellation. उठाओ microscope.
So you're using the constellation machine from Alcon?
Yes, yes.
Okay.
So reverse the image. So I have started vitrectomy. Zoom is not going up. Zoom to up. Okay, yeah. So this is the Ingenuity system, and it's a very institutional question. It's a very good, basically teaching device, and it's comfortable to the patient also, the surgeon also.
Norman, over the last 20 years, you must have seen a sea change in the equipments as far as the vitreoretinal surgeries is concerned, no?
Yes, yes. We started with a 20 gauge cutter with a Equirus machine from Elcon only.
Yeah.
So then we have shifted to 23 gauge, 25 gauge, and now we are going to 27 gauge. So along with this, the fluidics and all systems are also improving in the machine. So you can, if you see, you can see this is a cutter with a beveled end. So, and the cutting port is very at the tip of the cutter rather. So this is very comfortable and very easy to manipulate, particularly in diabetic cases, while peeling membranes and all.
And with a high cut rate, with a very high cut rate, and even the action on the retina will not be there even if you are going very close. And
so we saw vitrectomy during our fellowship days with a 700 cut rate, and now we are reaching 10,000 cut rate.
Yeah.
So this, particularly the bevel tip is very useful. And you can see this is a membrane here at the superior part of the retina.
I think very well and very nicely seen on the retroillumination. Actually, vitreoretina is a rare surgery. Live is quite rare to watch. Otherwise, normally we see only cataract surgeries and anterior segment surgeries.
Is this a flap of a tear or what?
Oh, this is a BRVO case basically. This is a, I can see a membrane here,
Yeah.
and there is a break also at this point.
Yeah, that's what I could see that maybe there's a tear here.
Yeah. Fortunately, the retina is still on.
Yeah.
It is a membrane. Also.
Yeah, this is a membrane.
Yes, and this is the membrane that Dr. Burman
Yeah.
is showing.
Yeah,
And, Dr.
yeah.
Burman, show the break nicely so that
This
everyone
is the
can.
Next
break
to
here, I
it.
can see.
Yeah, that is the break. Yeah.
So, sister, endocutter ready रखियो. So this is the beauty of this cutter that I can go very close to the retina actually. This is a,
Yeah, that's the advantage of this wonderful cutter.
yeah. The very controlled suction, I can go very close to the retina.
Yeah, it is said that you can actually shave the retina.
Yes. So at this point, you can see little lift, retina is slightly lifted also. So I'll use a tamponade here in this case.
So what's the age of the patient?
66.
66. Okay.
There is an elderly lady nearing state. So I'm going quite to the periphery of the.
Yeah.
My purpose is to relieve all the traction surrounding the brake basically.
Yes, yes. So just want to make it free and maybe a little bit of that fibrous membrane can still remain, but surrounding attachment.
Yeah, if part of the, if I can, yeah, I can leave part of the membrane, no problem. Only the, I want to make the brake free of.
Yeah.
So there is a small bleeding here. I am using the diathermy. Good. So this is, I'm using a fluid needle to check out the blood, residual blood here. এইটো ওলাই গ'ল নেকি? এইটো ওলাই গ'ল, সেইটো ওলাই গ'ল, কেনুলাটো ওলাই গৈছে। আমাৰ টেষ্টত নেজেল নাছিলে নেকি? So this is a backflush needle. So this
Yeah.
blood is quite sticky here.
Yeah, that's
And
what
not coming out of the-
yeah, I was just thinking that maybe a back flush will be a good option. Yeah, I think most of it has now come out in the vitreous cavity. It's dispersed, which can be taken out easily with the help of a cutter. Just aspirate out.
Hmm?
So after the back flush needle, you are using the cutter to remove the blood, right? That is dispersed. Is it the cutter?
Yeah, it is the cutter.
Yeah. So since the blood has completely got dispersed in the vitreous cavity, with the help of that back flush, you could remove that sticky blood and bring it to in the cavity, so that that can be removed easily with the cutter. By the suction of it, it can be sucked up, and the visual axis can be cleared up.
There is anybody.
The peripheral skirt also you are trimming so that there is.
After this, after Dr. Burman's case will be, we have another phaco case that will be phaco
Okay.
with VVT IOL. And that is case
Okay.
number 3. And the case number 4 will be a lower lid blepharoplasty.
Wonderful.
Okay.
So Dr. Burman will be giving the lasers now, right?
Yeah.
Yeah.
So after the laser, we can switch off to the other OT.
I'll do the laser, and whatever residual blood is there, I will take out at the end.
Okay.
Mhm.
But that was very quick, I must say, for a
Yeah.
vitrectomy, very quick.
Yeah. And he is a very fast surgeon. Like I see him, like he's always in the same OR day with me. He takes a 6-7 surgery, just finishes like a phaco surgeon.
So I'm taking laser parameter at 200 power and duration 100.
Mhm.
It's a band type of laser probe from the Alcon itself. Power of band probe. So advantage of this probe is that I can go to quite periphery.
Yeah. So what is your aim? Like, how much laser will you do?
Yeah, mainly I will do on this part only, superior part of the retina, because rest of the retina is quite healthy, and there is no any break also. So I'll just do laser to the superior part, covering the break, and I will use a tamponade here, gas tamponade.
Gas tamponade.
Yeah.
Which gas do you use? C3F8?
Yeah, I will use it. Yeah, I will use C3F8 only. Yes. Sister, foot nasal to noha kari pati dar porse le. Foot nasal to beya. Nala na paro ite convert. Ekbar kenne lo like sir. So this is a pigmented lesion here. I think it is a CHRP. Yeah.
Dr. Burman, can you show the chirpy?
This one, yeah.
There is a chirpy there.
Yeah.
And yes. So this patient had a BRVO.
Yeah, she had a BRV, superior branch vein occlusion,
Yes, yes.
along with a break in this one. So this much of laser is enough, I suppose.
And in any case, in the follow-up period, if the patient does require more lasers, you can always augment it.
Yeah, if necessary, you can do later also, no problem.
Yeah, yeah.
The black plastic is good. Yeah, black plastic.
Vitrectomy in vasculitis or in vascular occlusions, etc. These are quite gratifying because the patient feels very satisfied after the surgery.
Yeah, the patient satisfaction is quite good in this type of cases.
Yeah.
Black class metal, ARD pula hari perios. Black question.
That layer of blood that was all
Yes.
deposited on the retina now has been dislodged and it is in the vitreous cavity, which can be.
So now,
Now you'll use the cutter to remove the blood, right?
now I'm going to do a FZ here. FZ pressure total बढ़ाएगा.
Do you change any suction in such cases wherein you have already removed all the vitreous? You just
Previously I used a suction of pressure of 30. Now I have increased that suction to 60. FZ pressure.
Okay.
Yes, sir.
Okay, so you didn't remove the dispersed blood with the cutter. You just did a air fluid exchange or the gas fluid.
So the blood will come out with the fluid itself.
Yeah. Nice.
So this and macula both are quite healthy in this patient.
Yeah.
So for how long have you been using the heads-up system?
Sorry?
The heads-up system, for how long have you been using this?
It's for 1 year, yeah, almost.
Okay, okay. And are anterior segment surgery is also being done on this or only posterior segment?
Yeah, some surgeons like to do, yeah.
Yes, we are also keeping a phaco with Ingenuity.
Okay,
Either myself or Dr. BM, if the time permits, we'll take up one case.
okay.
After this,
Yes, they have.
so after this, we'll go to the next phaco, which will, now it is 4:35, right? Yeah.
Yeah, yeah, you carry on because
Very-
be absolutely comfortable. There is no
Okay.
hurry at all.
Okay.
Yeah,
Thank you so much.
very nice,
It
very
is
nice
going on
surgical
so well,
demonstration.
yes. It is going on so well.
Yeah.
Sister? Side view.
This. I'm having a bad throat today. Can't even talk. Not really, but 2 minutes. A gas exchange officer will go to the other OT. Ask them not to start, just to wait.
So Kasturi and Dr. Burman both, do you think there is some amount of lag which is there, which is generally said that it is there with the 3D, with the heads up system or with any heads up system for that matter?
There is little lag maybe there, yes, but not that much to disturb actually the surgeon.
Yeah.
Some people say there is little lag, but I don't think it is a very disturbing one.
Once you are used to that, then I guess it doesn't disturb at all.
Okay, this is almost all blood has come out. There's just
Yeah.
thin layer of blood is there. I can leave it. It will go by itself within 1 or 2 days. I don't want to traumatize the retina more. Okay.
Yeah. When we first used the Ingenuity, that was a problem with us. We used to find the lag was very high. And then company has modified it. Initially, it was 90 millisecond the lag. Now they have decreased to 50 millisecond. And they say that that cannot be perceived by a human brain. So even we feel that this time when the Ingenuity came to us, we found that this is better. The lag is much less as initially what we got 1 year back.
Okay.
I think
Yes.
anterior cortea, I think they are further modifying the system. But even for anterior segment surgery and also for oculoplasty surgery, now we find that the leg is much decreased.
So you're doing oculoplasty surgery also on it?
Yes, only when it's a planar, like not somewhere where you need to do a very plain surgery like lead reconstruction, like a ptosis surgery. Those are easy. But if you do fracture repair and all, those are not very easy. That we still need to try some more cases. When it is a single plane, like anything in the conjunctiva OSSN case or a ptosis surgery, those can be done well.
Okay, I always feel when you try to, you know, as far as you are up to the limbus, it is okay. But when you try to extend it to more beyond it, then somehow, you know, you can still do it, but you require a little more coordination for that.
Yeah. So now he's doing a FG, he's giving C3FR effect. And after that, then it will be followed by the closure of the wound.
So I have injected gas here. I can see a little leak in this sclerotomy. So I hope it will close by itself.
Yeah, but in 27 gauge, do you ever feel like, suturing the port?
Yeah, usually it is not necessary.
Apart from children, maybe
Yeah.
sometimes you may feel like, but
Yeah, but
adults very rarely, one can feel like, suturing the port.
yeah, sometimes in a thin sclera, there may be little leak here.
Yeah. True.
But it is okay.
So with this, we have come to the end of a vitrectomy surgery.
Wonderful. Very nice and very quick. Very well demonstrated.
Excellent.
Thank you
In
very
a
much.
short time, I mean.
Yeah.
Thank you
He
very much.
promised me 25 minutes and his
No,
exact
no,
it is
no.
25 minutes.
Yeah.
Okay. Now let
Okay.
us go
Thank
to
you.
Dr. B.F.
It's actually, it was very quick and
Phone
doing
kar
vitrectomy in 25 minutes. By
That too
45 minutes.
wherein you have to,
Bolo.
manage the break and all those,
Yeah.
all these things are really very, very well done.
Yes, Dr. Kasturi.
Yes.
So now we are coming to our next phaco case. This will be done by Dr. Balmukan Agarwal. He is heading the Department of Cornea, Eye Bank, and he is also working with us for the last more than 20 years. He's an amazing surgeon. He does lots of cornea along with cataract. So we will start the timeout now.
So,
For the timeout.
Yeah.
good morning, ma'am. Good morning, sir.
Morning, Dr. Balmukun. How are you? Good morning.
I'm fine, thank you.
Nice to see you in your OR behind a microscope.
Yeah. Yes.
Yeah.
So my the students will tell a little detail about the patient.
Yes. Yes.
Yeah.
My actually as well, Mr. This Das will assist me, Anjan Das, and another one person is also there, Dharmendra Nath. He will also. So these are the two people who are going to. So just tell about the patient.
So our patient is a 55-year-old female who belongs to Kohima, Nagaland. So she came with a complaint of diminution of vision in both eyes since 1 year. And on examination, we found that in the right eye, she was having the posterior subcapsular cataract. And in the left eye, it was the NS2 with dense posterior subcapsular cataract. She was a known case of diabetic and hypertensive. So she was on medication for that and it was well controlled. So on fundus examination, everything was within normal limits, but we gave a OCT macula for the investigation part along with the biometry. So biometry found that there was minimal cylindrical power of 0.3 diopter only, and OCT macula on both eyes were within normal limit. So we went ahead with the left eye phacoemulsification, which will be a 2.2 millimeter cataract surgery. So it will be a micro incision cataract surgery with a VVT multifocal intraocular lens implantation, and the power is 23.5 diopter in the left eye. So we'll be proceeding towards the surgery.
So I'm going to start the surgery, ma'am.
Yes. Yes. Please do.
So first of all, we'll make the side ports in the front.
You are also using Provisc, Dr. Balmukar?
Yes, yeah, ma'am. You always used to Provis
Okay.
preferred, but even other Hilons also I keep using. But we in our hospitals we generally give Provis. So I'm going to make a rexis here.
I think very nicely made. Some of the basic steps so well done that, with each nick, Dr. Balmukund is going right till the edge and, again, redirecting it.
Please.
So it is. So some people do make needle rexes, and I know that Dr. Rajesh does with the forceps. So Rajesh, what do you think? It's
Yes,
just
ma'am, it is up to forceps or other thing, but I'm very much used to
the
the needle
needle.
one.
Yeah.
Sometimes in some your hypermature cataracts and other cases where I need something both, I use even this one. So I
Forceps.
prefer to use. Yeah, ma'am. Forceps.
So I think very nicely demonstrated, and because it was being done from the side port, the chamber was absolutely did not lose the chamber at all. What was the size of the keratome that was being used here? 2.2 or? Okay.
Yeah, ma'am. No, आप सीधा देखिए, लोग सीधा सीधा सभी. So it's nicely rotating.
Yeah, very nicely.
Free. It's nicely.
Very
So,
nicely rotating and free.
Yeah. Now we give some amount of Scott to keep the Vislon and give some Vislon about top of that Vislon there. So I always prefer to do some little bit of saving first to have a better space in the AC to quite away from the your endothelium. So I save entire part little bit and then I go for sculpting normally. And then I go for chopping.
So you're using the balance tip, right?
Yes. Yeah, I most of the cases I use balance tip. Yeah, I have used.
So if you do a little bit of shaving here or
entirely I do shaving. So we are quite away. So that help us to quite.
Yeah, create space for things to
right. So
very nice trench.
We have separated also.
Perfect. I think that was a perfect job.
Yeah.
So it's quite two parts already.
Beautifully separated.
Light bada chop. So I have separated.
I think that was excellent, and I think the best thing to watch was that how the left hand was moving, separating, more than the central part, more than the right hand, which was just in the center. So I think parameters can also be seen very nicely. The vacuum, aspiration rate, everything is visible on the right side of the panel. For the people who are watching to know that what should be the parameters.
The parameters, you just show them the parameters.
Yeah, we can see them that is coming on the panel, Dr.
So finally now we have completed the lens part. Now the cortical part will clean.
That was very quick, I think, because you made this trench, it became a lot more easier, and then all the things came out very quickly.
Right.
Yeah, actually, I would say every step was done very well. And if you do every step in a copybook style, then it becomes very fast automatically. You don't have to make efforts for it, no?
Right.
Because
true. Very true. Very true.
Very good hydrodissection made the nucleus very mobile, very easy to move. Then good cracking, good trenching, and then cracking and separating. So everything was done in a very nice, the way one should be taught. Good demonstration.
Yeah, textbook.
Yes, absolutely textbook.
Now I'm doing little bit of polishing and cleaning the posterior, some part which are now adhered to the posterior capsule. So I'm doing some amount of.
So the beauty of this machine, that is Centurion, is that it has a epinucleus mode. Although Dr. Balmukund did it so well, it was so well, separated that he didn't need to use it, and maybe
Just
it
give
can
me
be tested on the
and
foot.
some amount I will try to clean with the jet of the water. So few fibers which are adhered now. Now you see,
Yeah.
I'm cleaning
Yeah.
those parts. So that, no, don't move. Yes. So that
And-
part you can clean with the jet of water. If it
Yeah,
doesn't come.
it's a good thing. It's something which
So it's-
works.
So this is the way we can clean the anterior part, as we are going to use the BBT lens, multifocal. So that's why it's better to always, the posterior capsule has to be very clear, and this one. So that's why the multifocality action has to be there. So we don't clean, then patient may not have that effect. So, yeah. So now, I mean, so this is the lens. Now this is the lens, the important, but here it almost like a monofocal lens. Here, if you see, there are no rings at all.
Yeah.
We can't see any rings. It's almost be absolute like a. But the important thing is that it is this lens is very forgiving lens, and is a very flexible defocus curve. So that is the advantage. So most of the surgery acceptability is very high for the surgeons, and really it is a forgiving lens, and it is having a non-diffractive plate. So non-diffracting pressed by peak correcting IOL. So that is, and it has all the ranges from right from this distance to intermediate and your focal near.
I
So
think
that's
we also saw a very nice demonstration of how an intraocular lens has to be placed into the injector by putting first the haptic and then again placing the
Yes.
trailing haptic over it, and again very nicely implanted. Almost effortless.
Now here there is a central part which is very seen. It will only at the 7x zoom we can see. Can you see the reflex?
Yes.
I think if you can see the reflex.
Yeah, we
we-
can see.
So that is the important visual. So without your 7x, it's very difficult to see naked eye. We can't make out, as we can see in your other, your panoptics and other restore other lenses. I think. So it is almost the centered lens. So one thing I can use, sometimes it's better to use in cases, use the pilocarpine to see the centration also. So which helps you a lot, and your lens also remains. So in those cases, I prefer to give little bit of your pilo also, because so I'm giving this pilo. Don't move. So, yeah, it looks absolutely. Yeah. So I think it's well centered now.
Yeah,
Yes.
it looks like absolutely.
So I have washed all the pilo. We should not left behind and behind the lens. So this absolutely wonderful. So the surgery is over. Thank you so
Wonderful.
much, ma'am. Thank you, ma'am.
Thank
sir.
you, Dr. Valmukund. That was
Wonderful
one of
surgeries.
the excellent surgeries that we've seen on a
Yeah.
live platform. Absolutely
Yes, sir.
textbook like
Thank you.
picture.
Yeah,
It was
now
a good
Yeah.
teaching kind of a surgery, the way one should teach the fellows.
Yes, this. So this is last I have given we used to give vancomycin. So I finished with that. Thank you so much.
Thank you.
Wonderful.
Thank you so
Thank
much,
you.
Dr. Balmukund. Thank you.
Welcome. Thank you, ma'am. Thank you, sir.
Thank you.
Wonderful.
So I have just one question, Dr. Balmukund, for you. If you do a bilateral implantation, especially for the Vivity intraocular lenses, So would you put them, both of them emetropic, or would you like to, target one a little bit of myopia?
Particularly, ma'am, VVT lenses, they are little better for your intermediate patients, but like your panoptics, which works better in the near one. So in one eye, I will always prefer in VVT 0.25 myopic in one eye. And on one eye, I will try to make it emetropic.
Okay.
So that's how I'm doing last, and the patients are absolutely wonderful. They have no complaint till now. Moreover, I told you it's a forgiving lens. Even it is little decentration also, patient may not complain of glare and halos and other problems. So that's the reason of being chosen this lens to give this patient this lens. Ma'am.
I think that was excellent demonstration. Again, each of the steps done so meticulously and so well.
Thank you, sir. Thank you, ma'am.
Yeah, that was a very good learning experience. Actually.
Thank you, sir. Thank you.
So we have the next case ready, Dr.
The
Balma.
operation khatam hoise de.
Yes, we are ready with the next case. Can you see us?
Yeah, we can.
अच्छा से focus नहीं हुआ. आप इस तरफ आइए.
नहीं, focus हो गया कस्तूरी अच्छा से.
Yeah. आप इस तरफ आइए. Can you see the lower lid? यहाँ focus कर लीजिए. यहाँ.
Yes.
Yeah, we can.
It can be seen, no?
Now we
Yeah.
We have just given a traction suture for the lower lid, and then I'm using this demars, and then we are everting it. Is it visible to all?
Yeah, visible.
Yeah.
So what is this a case of?
This is a case of lower lid blepharoplasty. She is 72 years old lady. She has got all the prolapse of the orbital fat. So we are planning to make 3 flaps of the orbital fat and transpose it to the down to the maxillary region. Okay. So there are different ways of doing a blepharoplasty. One is we only excise the fat. Here we will use the fat as a filler. So we will not be excising the fat. So approximately, you can see I'm giving an incision, I'm marking it approximately 4 millimeter below the tarsus. Can it be seen?
It is, your hand is coming in the view. Actually.
Now, आप एक काम कीजिए, इस तरफ आइए.
will have to show from there.
Or किस तरफ? Now can it be seen?
Yes, we could see it.
Can you see this
yes,
incision
yes,
that I'm
yes.
marking?
Yeah, now it's better. It's much better. Very well seen. Yeah.
Okay, give me a tooth.
With what are you
So,
marking this with? This is
I'm giving approximately a marking 8 millimeter below the lid margin. And then give me a, hold it. This is the conjunctiva. Can you see this? I don't know. Not seen, right?
No,
I
not
have
see
to,
your hand is
now
seen.
if I use my other hand, this is the
Yeah,
conjunctiva.
now we can, yeah.
Okay.
We can see.
Now I'll try to expose the, give me a 6 of white field. I'll try to expose the orbital septum. Give me the thing. But I don't think it is seen well, right?
So we can see the lower lid, then we could see the conjunctiva also.
Can you see the structures?
So somebody has to, that drape is coming from this side. So if somebody can just push the drape. Yes.
इधर आप इधर focus कर लीजिए इधर.
थोड़ा सा drape, you'll have to push the drape a little down.
If you
And
want,
then
Sister Gun Gusai, just wait. We are trying to focus. Let him
I
come.
know, I mean, it's really challenging to do
There by
a lid live surgery. Yes, now we can see.
I'm just putting a suture in the conjunctiva so that it helps me to know the plane when I try to close the wound. So give me the bipolar white one. Okay. So is it visible now?
Yeah, now it is visible.
Yeah.
Okay. Monopolar.
So is this a bloodless cautery that you're
Yeah,
using?
this is a monopolar I'm using so that there is no bleeding. Okay.
Yeah.
Can it be seen now? Give me a
Yeah.
contour.
Yeah.
Yeah. now I'm trying to find out the orbital septum. So once I give incision over the orbital septum, okay, you will see the fat prolapsing out. So this other, can you see, this is my medial fat, this is my central fat, and this is the lateral fat. Okay, yeah, pakad lijiye. And now I will make an incision on the orbital septum. So I'm just holding my orbital septum, as you can see here, and try to make incision on the septum. And then this will, can you see the fat is prolapsing?
No, now we can
Yeah,
see.
now, yeah.
Can you see the
Yeah.
fat? This
Yes,
is the
yes.
orbital fat. And now a very important structure is the inferior oblique. I need to separate the medial from the central. And once I separate this, as you can see here, hold this, you'll find the inferior oblique muscle nicely sitting. I just want to show you the inferior oblique. Can you see this is the inferior oblique muscle? Wait, let
Yes.
me separate it. This is my, can you see how I'm touching
Yeah,
the inferior oblique?
Yeah.
So this is a very vital structure, and any injury to this, clean it, wait fast, clean. Give me the gauze piece. So this, hold this. This is the inferior oblique. Can you see this is the muscle here?
Yes.
Okay. So this is my medial fat pen. Then likewise, this is my central fat pen. Hold it here, one of you. And I'll separate the lateral from the central. Because of some fibrous tissue, very often you can see these two are usually joined up. Give me a forceps. Sister, forceps. Sister, come here, forceps. Give me a gauze piece. Is it focused? Can you see?
Yes.
Now I have got three beautiful.
Yeah.
This is my medial, this is a central, and this is a lateral. Can you see the?
Yeah, very well.
Yeah.
Very well.
So these are the, I'll make it more longer. Let me try to separate it. Give me a artery forceps.
We can see very well, Kasturi. It is
Okay.
well focused and nicely
I'm
magnified.
trying to go more further deeper to make the. So this is my, give me one more artery forceps, lateral fat pen. Give me artery forceps. This is my central fat pen. Okay, hold this. And this is my medial fat pen. And the beauty of this, you see, the plane of dissection should be so correct. This is my inferior oblique. Give me Johnson bar. This is my inferior oblique. Can you see this is the inferior? Hold it with your artery forceps. Okay, you leave this. Leave this.
Your
this.
inferior oblique is in between the two.
Yeah, this is the inferior oblique. So in the lower lip, this is a very important structure. This muscle lies between the medial and the central fat pad. Any injury to this muscle might lead to a postoperative diplopia. So you need to make these three beautiful fat flaps and then leave it. All of you leave it. And now what I'm planning, I'm planning to transpose this fat. So there is something called the orbitomallear ligament. This is an osteocutaneous ligament that extends from the orbit to the skin. Okay?
Yeah.
Loosen it off. Cut it off. Cut it off. Okay. So this is where you find this osteocutaneous ligament, that is the orbitomallear ligament. This is causing some obstruction. Now this is a better view, right?
Yeah.
So this is causing the obstruction. Now what I will do, all the three flaps that has been fashioned, this is medial, central and the lateral, will transpose it down to the soup. Okay. So this will act as a filler. This will act as a filler and efface this lead cheek junction. So we are not excising the fat. All the prolapsed fat, we are using the same patient's fat only, and we are transposing it down to the cheek region. So can I have a PDS?
So for us, this is spectacular, Kasturi, because we've never seen anything like this before.
Yeah. So this is a monofilament absorbable suture. And so I'm using this. Cut it. इतना लंबा नहीं चाहिए.
So here the fat is acting, the patient's own fat is acting like a filler.
Pardon, madam?
I'm saying here the patient's own fat is acting like a filler. So there are no
Yeah.
artificial fillers, huh?
The fat itself is acting as a filler for him. So we don't have to use filler. The same fat, what I'll do, I'll transpose it. Normally we should use double lump suture. So what I'll transpose it. Oh, she's getting pain. On a block. So I'm transposing it deep down to the cheek region. Can you see?
Yeah.
Yeah.
So now this will put the fat down. So can you see this whole fat, this medial fat, this is being pulled inside.
Yeah. We can
So
see.
give me one more suture.
So it's kind of, you're kind of hitching it over onto one side. It's like a hitch
Not
suture.
anesthesia, just. I'll just put little anesthesia. I think she's having little pain.
So what anesthesia do you generally use in these
This
cases?
is 2% xylocaine with adrenaline.
Okay.
Since I'm touching her eyelid, she's getting some pain. Demands. Cut this. So now I'm holding the central, release the demand a bit. Now put the demand. So now I'm holding the central fat pad. You can see this is my central fat pad. So this fat also I'll transpose it down to the cheek. This blepharoplasty happens to be one of the most common surgery for all the oculoplasty surgeons. And this, take it off.
This is part of
exactly the
aesthetic as
second
well,
fat
right?
pad will also be transposed deep down to the cheek region. Release the demands. You can see this. I'm just going above the periosteum, and can you see my needle very down here?
Yeah,
Can you see down into the cheek region?
absolutely.
So this is the second pedicle of the fat that is being transposed. Cut it here. And lastly, I have the lateral fat pin.
So is it that wherever you have this fat available, you always transpose it like this? What if the patient comes for the fillers? Otherwise, would you use artificial fillers for such patients? When will you use artificial fillers for such patients?
Yeah. Initially, when I started my surgery, I used to excise all the fat. Then in the long run, because those are young patients and they really feel good at this when the fat is being excised. Then after 5-6 years, I have realized that the tear trough, that is the hollowing around the inferior orbital region, is very, very high. So after that, I have decided that it is better we should not excise the fat. And a big research has been conducted all over the world. And they have decided that we should not excise the fat. This fat, we should use it as a filler to fill this gap. And this is the infraorbital rim, so that there is a good effacement of this lid cheek junction. Now, if you look from here, you can see this is the put. This is my fat. This is all the 3 fats that can be seen. So what I'm doing, I'm using the patient's fat and then transposing it to the cheek. So once this is done, give me a needle. Since it's a monofilament and it's absorbable, I don't even use a bolster for it. Directly I suture it to the skin. Aku diba, huh?
Okay, so you don't have to remove this suture, it will get absorbed on its own.
Put the needle there in the middle suture. Like this.
So when you're using fat as a filler in different patients, the amount of fat
Yes,
that you get to
fat
use
is-
as a filler would be different.
Yes, fat is a filler and also it's a stem cell. This
Okay.
fat, orbital fat is a stem cell. So this is how the fat pads are gone. And this has also taken care of all the swelling that she had had. And there's no much hollowing here. So all the 3 fat pads that were, prominent, that has been used and fill it up. So the closure is very simple. Closure, even if you don't give a conjunctival suture, it is okay. But I usually like placing around 3 conjunctival suture. Demonstration. Reverse direction. So one end is already there, and now to the other end of the conjunctiva. Pull her out. It's not a very good case because we had a young, nice lady. She also came out to be COVID positive. So we had to change and take this lady. Got it? So even if you give one suture, it is okay. And this is the end of the surgery. So this fat is very interesting. I have done the research with IIT Guwahati, and I have seen that this orbital fat, especially the medial fat, it derives from the neuroectoderm, and the lateral and the central is mesenchyme. So we have done a transdifferentiation, and we had seen how this adipocytes, can be transdifferentiated. And we found that it could be transdifferentiated into osteocytes, into chondrocytes, and most important, we found the neurogenic differentiation. And when we searched the literature, we found that this is the first study to show that orbital fat can have a neurogenic differentiation. So now we are planning for translational research. If we can have this fat, especially in those bad cases of Stephen Johnson's or all this situation where there is loss of ocular surface, dryness and the disease, so we can use those fat. And in case it gives a very good neuroectodermal differentiation.
That's wonderful.
That was really wonderful. That was
We'll go
actually,
to
yeah.
next very interesting case that will be done by Dr. Nilutparna. She will do a small incision SICS. Like she'll do a 3 millimeter incision through which she'll put a 5.5 millimeter PMMA lens.
Okay.
So then after that, Dr. B.M. Agarwal will be doing a Pterygium, and then I'll be doing a complicated cataract of very high myopia, minus 16.5. And then we'll do Ingenuity if time permits. Okay, thank you very much. So this lady is doing absolutely fine. And I'm
Thank
being
you.
assisted by your student, Dr. Vatsala here. And
Oh,
Dr.
nice
Obed.
to see you,
Okay.
Vatsala. How
Hi.
are you? So nice to see you.
Hi. Vatsala, sir,
So-
how are you finding there? How are you finding the place? Learning a lot from Dr. Kasturi?
It's a different change of pace from Delhi, sir. Lovely weather out
She can't say it is better, she can't say it is worse.
No, but it's a good experience,
A
right?
good experience, yeah.
Yes, absolutely. And Dr. Obed is from MEMC.
Okay,
So-
Okay.
another one from
He is
Delhi.
also from Delhi.
Nice to meet you, Ved. Nice to meet you.
So thank you so much. Let's go to the
Thank you.
next case. Next case.
So Kasturi, you're so well organized and so well timed. Everything is moving, by the clock.
Yeah, and everything is moving fast. Nice.
So I think Dr. Nilat Purna, hello, how are you?
I think this Center वाला तेरे
I
हाथ में
think, yeah, the mic has to go to a.
ठीक है okay.
Can we have the microscope view, please? Or somebody will tell us about the case.
होता है लाइफ
So I think we've had a variety of cases, Rajesh, today.
Yeah, wonderful.
Blepharoplasty, which we've not done ever before, I think,
Yeah.
on this platform, the first one to be done.
Very true.
Cataract surgery and yet another cataract surgery now, and that too an SICS. So we have a full variety, full jargon of cases. So Dr. Nilipurna, can you hear us?
Yes, ma'am. Good evening, ma'am. How are you, ma'am?
How are you?
Evening, Dr.
I'm fine.
Okay. So Nilipurna is the representative of, I don't know what they call, but from the northeast of the young ophthalmologist group, Nilipurna. Am I right?
Yes. Oh, one second. Let me focus.
I think
Good
small-
evening, everyone.
Yeah.
So we have a 58-year-old male patient who comes to our OPD with the chief complaints of diminution of vision since 1 year. Visual acuity in the right eye was 6/24 partial and in the left eye was 6/18. On slit-lamp examination, the anterior segment finding, we found
Cornea.
that the cataract grade in the right eye was nucleus sclerosis grade 2, cortical cataract, along with posterior subcapsular cataract in the right eye, and nucleus sclerosis grade 1 in the left eye. Posterior segment examination was within normal limits in both eyes, and we came to a diagnosis of immature senile cataract in both eyes. So we planned for MSICS in the right eye for this patient. On doing the biometry, right side findings were as follows. The axial length was 23.84 mm. The K1 value was 41.90 diopters and 8.05 mm at 97 degrees, and K2 value was 42.88 and 7.87 mm at 7 degrees in the left, 7 degrees. The cylindrical power was minus 0.95 at 97 degrees, and the IOL power calculated at 118.5 diopters was 21 diopters.
Okay, good evening, ma'am. Ma'am, actually today I'm going to show you a 2 millimeter MSICS. So I'll be beginning the surgery. The purpose of showing this surgery is that we can also put in a foldable IOL through a 2 millimeter SICS incision. And also we can also reduce the carbon footprint of the surgical procedures. So let me start. This is a side port incision that I am going ahead. I will be using trypan blue in this case, so that gives me a good visualization, as well as it also increases the rigidity of the capsule. The AC wash. It is important that one should see the cannula inside the side port tunnel before they put in the fluid. Now here I'm using a hydroxyl methyl cellulose. I'm not using Provisc. You can see the wave coming in through. I usually prefer to go ahead with anti-clockwise rexis.
So what would be your size of rexis, Nilipurna, in this case, because you're planning a SICS?
Yes, ma'am. Since I'll be doing a 2 millimeter, so I would prefer the rexis size to be around 5, because the optic that I will be using will be 5.5.
So the main idea before I close in the excision is not to come in, but to go out and complete it in a circular fashion.
So you have gone out and completed it in circular
Yeah,
fashion.
yeah, not inside, because that
Yeah.
creates a like a heart-shaped tag. So I don't have a tag right now. So I'm inflating the bag. I mean the AC. Sorry, not the bag, the AC. So the peritomy in this case will also be a little bit smaller than the peritomy that we use. Here I'm doing a superior tunnel. So the conjunctiva as well as the tenons.
So can you center that part where you are dissecting?
Yes, ma'am.
You have to move it away from you. Yeah.
Yeah.
Yeah. Now perfect.
So it is better not to go ahead with small cuts, but big cut once, and then you go. If your tenons is quite easily, you can see, you can make out the tenons here, ma'am. So if
Yeah.
your tenons is detached, the peritomy easily falls back. You need not give a relaxing incision also.
Yeah.
So in this 2 millimeter, I will be giving two small back cuts 1.5 millimeter behind. So what I will do is that I will try to cauterize only that part that I require, not all the perforating arteries. One quarter. On. One quarter. On. Fluid. This is a bipolar cautery. One. On. So I'm going a little bit behind because I want to make the side incisions 2.5 millimeter behind. So this is what I'm using. So I'll use a frown incision here. So this is the frown that I have made. Now I go in towards the cornea.
Just center it, Nirupurna. Make it.
Is
move.
it?
Yeah, better.
Oh, 1 minute, ma'am.
I think you'll have to ask the patient to lift up the
Only the
chin.
tunnel part, is it? Yeah.
Yeah. Yeah, now it is okay.
So the incision I have made, I'm going in the cornea. I go ahead with the side pockets little bit, not much. The main idea behind this is that you should not lift it so that it does not cut through the tunnel, because it's a very small tunnel that we are engaging here. So after once I'm satisfied that yeah, the scleral pocket and the corneal tunnel is made, so I'll now go behind. I see that there is a perforating vessel here. I'll just cauterize it before I go ahead with Nidiba. Yeah. Wash. It হৈ আছে তো মোৰ হৈ আছে. So these are the back cuts that I'm putting here.
In such cases, the wound construction is probably the most crucial
Yes,
step.
ma'am. Yes, ma'am. Now, the important part of this wound construction is that here, in order to maintain the square geometry from the cornea up to the sclera here, the ergonomics of this is that if we don't create this wound properly, then once we take out the nucleus, it's going to create a purse string effect, and the purpose of the tunnel will not be served for 2 millimeter.
So actually it is 2 millimeters wide, but there are 2 extensions which go vertically at the back.
Yes,
so how far
I
do you
have.
go at the back actually?
Sorry, ma'am.
How far do you go at the back?
1.5 millimeter behind, that much only.
Okay, okay.
So the sclera itself gives into the elasticity so that I can put a PMMA. This 2 millimeter is easier for us to put in this one, what is that called? The foldable IOL, ma'am.
Yeah.
But for PMMA, for those who are working in the periphery and wants to do a 2 millimeter, will receive good results with this technique. Now, I would like to acknowledge at this point of time my teacher, Dr. Crescento. The wound is not complete, ma'am. I have not gone in the cornea actually.
Okay.
So will you be dividing the nucleus so that it is delivered through this smaller incision, or
the nucleus, sir?
Will you be, doing any nucleofractus method?
Yes, 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 sir. I will fracture the nucleus.
Yeah.
Before delivering it, so that
Nice.
so that dip and straight again, and then we cut in through the sclera also. So that is it.
Okay. So I think the most crucial part, like I thought, and it came out that only is the wound construction.
Yeah. So we have done a hydro dissection here. You can see the wave coming out.
Yeah, very nice.
Yeah.
So can we? Yeah. Now we can see the central part. It's good.
Put in a little viscose. So before doing the hydro dissection, I have done a little decompression of the globe. Now this, sorry, it's not coming out, but this 2 millimeter is very good for soft cataracts that you can fragment in the AC. And for harder nucleus, you can also fragment it in the bag, and then you can take it out. So put in the visco behind the nucleus as well as above it. So here I would like to thank Dr. Amulya Sahu sir for teaching me this technique. And this is his instrument that I am using. This is the practice that I'm using. And this visco cannula is going to fragment it while I am injecting the visco simultaneously. So you see the ease with which it comes out.
So this vectors is different, or is it similar to the one that we normally use?
No, ma'am, this is a different one. This has been made a little stouter and smaller in size so that it goes inside the tunnel.
It looks slimmer than what we have.
Yes, yes, ma'am.
Bigger ones.
Yeah.
Okay, so that was a very good separation of the nuclear fragments that you did. And like you said, very easily it got fragmented with the visco cannula and with the vectors.
Yes, ma'am.
Vectors and the visco cannula.
So I think I have got 3 pieces here now. Actually, it should have been 2. So anyways, we can, since we are using a lot of viscoelastic, we can take it out at your own convenience, whether you want to make it a trisection or a bisection accordingly. So it's very soft. I'm not going to use the thing anymore. I'll just use the visco visco to take it out. So we depress the lower lip and it comes out easily.
Yeah.
Yeah. Nice.
Very nice visco expression of the fragments.
I need a little bit of Here to this. I'll try to use this once more.
So this is not a irrigating vectors, no, it's a
No,
dry.
ma'am, it's not a irrigating vectis. It's a stout vectis.
Yeah.
Head to cannula. I want to show you one more thing here. This is a multi-jet cannula. Can you see, ma'am?
Yeah.
Yeah. So this multi-jet cannula, it washes off your endothelium also, and even over the iris. So you can see clearly what you are actually going to do. So I'm going in through the main port now, taking out the smaller fragments. The advantage of this technique is that we can even go ahead with temporal ones and also in the steepest meridian. So that is the good thing about this. I'm taking it a little longer time than the rest of the surgeons because this is a new technique that we have been doing.
It's very well being done, actually. You are explaining every step very well. So,
Thank you, sir.
good.
The entire set that I'm using is Dr. Amulya Sahu's.
Okay.
Yeah. So he has actually customized this set for the 2mm SICS only. Downward to this. Timeless. Fluid to halka hai na. Tube to sokuta hi se. This is also a 24 gauge cannula that I'm using. Yes, sir. So I'll show you how to put in the IOL now.
So you're going to put the IOL with the injector or
Yeah.
with the 2mm.
Then we can move ahead with the rest other surgery. It wash this clean kurda.
So at the end of the surgery, do you need to suture the wound or you just?
No, ma'am, we don't need to. It's a self-sealing wound.
Okay.
I hope it goes in today.
Which intraocular lens you are putting?
This is a PMMA IOL 5.5 optic that I'm
Okay.
using. Now the deal here is that since I'm creating a 2mm here and 1.5mm extensions here, so it creates a hypotenuse of around 5.5mm here, and because of the sclera, it gives away. So you can see once the haptic is inside, I will be able to put the optic also. Can you see it has gone in?
Wonderful.
Quite easily.
Very nice. Very
Yeah.
nice.
So with this technique, we can even go ahead with
Can even maybe do a foldable intraocular.
yes, ma'am. We can go ahead with foldable. We can go ahead with multifocal. We can go ahead with any IOL that you wish for. And if you want to decrease the astigmatism part, then we can go ahead with the steepest meridian incisions. So tap the lens
So
in the
what is
center.
your preference? Like you do superior or you do temporal?
Sorry, sir.
What is your preference? do you do temporal as well, or along with-
Yes, I do temporal as well as superior, but for the learning curve is, since it's an advanced SICS technique, so the learning curve, the students that they learn is superior. So I would prefer that they first start with the superior, then maybe go ahead with the temporal later on.
Okay.
No, I was just wondering, is superior a little more easier to do as compared to temporal, or is it just the same, or it doesn't matter?
It doesn't matter actually, ma'am, because once you have gone ahead with basic SICS techniques, this does not create much of a difference later on. So wash.
Okay,
Center
so
asata?
This
Okay.
is also sutureless.
So,
So I think,
no karbe. Cauterize. So this is done, ma'am.
excellent, Nilotpurna, excellent.
Thank you so much.
demonstration.
Thank you so much, sir.
Absolutely.
Thank you for the
on-
opportunity.
No,
Excellent.
absolutely on your technique. Yeah.
Yeah.
A new way of doing SICS and really done very
Yes.
well. Very well.
Yeah, it's a new technique that actually, as we are advancing with phacoemulsification, we also want to show that even SI surgeons who are doing SICS can also evolve into newer surgical techniques so that they can keep up with the advances in the technology. And basically, SICS is a skill-based surgery. So
True.
I think we should not forget that we need to have our skills intact before we get dependent more on the machines.
True. Very well said. Very well
Thank you.
said.
Thank you so much, sir. I still acknowledge Dr. Amulya Sahu sir for giving me his set. This was a gift from him. And I thank AIOS for the opportunity. Thank you so
Thank
much.
you,
sir.
Nilotpurna. I think the biggest gift was the skill that he gave you.
Yeah, the skill that he gave you, that was the biggest. And I would also like to salute him.
Thank you, sir.
Yeah.
Thank you so much, sir. Itu dia microscope ta kar diya. ইফালে on কৰিব দিয়াচোন, এইটো বন্ধ কৰিব।
Yes, Dr. Balmukund, are you ready?
Yeah.
Dr. Balmukund, I think he's doing a pterygium surgery now. We've had a variety of surgeries, right from anterior segment to intraocular, extraocular, SICS. So it has been a really treat to watch. Dr. Balmukund, can you hear us?
I guess he cannot hear us.
So I think till the time they sort out the issues related to audio, Rajesh, what do you normally do in a case of pterygium? I think almost all of us are using autoconch.
Yeah, we all do autoconch, and in a primary treatment, yes, autoconch is something which preferable and which is done all the time. Regarding autoconch, many people, they like, even in our center, we have done that study regarding the blood as well as glue. Some people use sutures, but most people have now shifted to glue or blood to stick the autoconch. So let us see what exact idea Dr. Balmukund is going to show.
ये लोग रेडी नहीं है, अभी हम कैसे सर्जरी करेंगे, दिखाएगा।
So
How I'm going to see.
can we have the microscope view, please?
Yes, that's what a microscope.
Yeah, now we can see. Now
Can you see?
we can see now.
You
Are
can
we
see
seeing
the
the?
can you
Yeah.
see the ma'am Pterygium?
No, actually,
Oh,
yeah,
yeah, now we
now
can see. Now
it
we
was
can.
some other microscope.
अरे
We
मैं
can
मैं
see.
वो ताते मैं बस मैं किमान
We can see the pterygium and we can see the
We
little
can-
bit of
yeah.
cataract.
so
Flesh sheet
she will,
Pterygium.
ma'am she will tell you in detail about the patient.
Okay, okay.
So my Dr. Shisham, she is our DNB student. She will tell you, ma'am.
No, we
Can't
can't
hear
hear
you.
you. You have to put your mic on.
Yeah. So this is a 68-year-old male patient man who came with the complaint of diminution of vision in both the eyes since 1 year and with fleshy mass growth in the right eye since around 2 years. So on assessment, the visual acuity in the right eye was counting fingers at 1 meter. Am I audible? Okay.
Yeah, yeah.
Yes,
Very
we
much.
can hear
Counting
you.
fingers
Carry
at
on.
1 meter for the right eye, and for the left eye, it was 618, which was improving on pinhole to 612. Anterior segment examination showed pterygium grade 2 in the right eye and a cataract grade of NS3 dense posterior subcapsular cataract in the right eye and NS2 posterior subcapsular cataract in the left eye. IOP was within normal limits. Autorefractometry findings showed around astigmatism of minus 2.5 in the right eye. So we had advised topography for this patient, and the findings corroborated on the topography, where we found an astigmatism of around minus more than 2.5, 6.7, around 2.67. And so we had planned the patient for pterygium surgery first and cataract surgery at a later date. So we'll be seeing pterygium excision with autograft and TCL glue.
So ma'am, I'll start the surgery.
Yes, yes, please, please, please.
Yeah.
Dr.
So ma'am, I always prefer to do in my most of the 90% cases, conjunctive limbal autograft. And for the last 15 years, I always take my graft from the inferior part, not from the superior conjunctiva.
Okay.
The reason is this: the patient remains very comfort because there is less movement of the lower lid. Another reason is in the future the patient might require the trabeculectomy surgery, so we never know. So that's why we can save that conjunctiva and the PEPS. So I'll be showing you the inferior conjunctival autograph.
Okay, perfect.
And I will be using the TCL glue.
Okay.
So now I'll start my surgery. First of all, I'll make a nick at the limbus. And I'll try to.
Can you just focus it a bit?
Center it towards you. Yeah.
Can you see?
Yeah.
Little bit more.
Little bit more.
No. The other side.
Other way around. Now we can.
No, because there is some disparity between the microscope and.
I think they need to put the inverter on because this must be set for the posterior segment and.
Problem আছে তোমার লোক কথাটো বুঝায় না no madam there is no problem হয়ে আছে so is it okay now ulta হয়ে আছে
slightly
inverted I think
inverted it is inverted actually that's why it's getting problem ulta হয়ে আছে you just change it is inverted you might No, it inverted है ना it more hard to উপরত আছে it showing down it is inverted it should be rotated so I'll separate the conjunctiva from the subconjunctival fibrovascular conjunctival mass at the limbus
Yes, we can see it now.
change kori thaken na etu korone problem so there is a fibrovascular mass which is there
Yes.
Yeah, we can see.
So you can see this, which is I'm separating the big fleshy mass. Now once we separate it, yes, it is there. Once separate. So while separating and doing this, as it is very vascular, so that's why there will be bleeding. We have to cauterize. And while cutting, we must say that your medial rectus tendon should be this one. So the bleeding, cauterize. So there. must be. Tunda na itu doh hai. Tumi itu di dhora. Mo tham kete. Was the agent? Yes.
I think it is quite a big pterygium and it looks
Yeah.
very big also.
It's very fleshy and vascularized.
Yeah. बंद खोला बंद करा एक बार. This is बंद करा एक बार. बंद करा बोली कुछ. मैं धरी बुद्धि है ना इधर. So we have to hold the things. There was there. Was. Then now swab. दिया हेतु तो कोई ऐसे मोर सर्जरी तो एकदम माने उल्टा करी दी एकदम प्रभाते किबा किबी चेंज कराए सब माने माथा में दादा जो भी है बट अभी देख now
I think now it is moving in the correct direction.
the now on
Yeah.
it's on
Yeah.
Yes.
देखा आपको गोल ओए माइक्रोस्कोप पे इतने गोल माइक्रोस्कोप क्या गोल कर लीजिए यार ना तो ले माइक्रोस्कोप ये इरिडिएशन है Katibodiation. Ever Vanas. So once I have separated now, so I think bleeding will stop slowly.
Yes.
Nothing to worry. So now I'll try to do the tracheorexis. I'll try to remove as far as possible. Try to rotate. Sometimes it doesn't come in one go. Sometimes it comes in the piecemeal, but I think so now Mehdi, oh, no. So I'll try to clean the wash the swap. So I'm now. Was there. So almost this is the clean. No much of tissues are left here. So cautery. Yeah.
So although it appeared to be very fleshy and angry looking,
Yes, ma'am.
it has come out in one go.
Yes, ma'am.
Yeah.
Yeah. So I think this is now measurement diya Kuribokan. Now I'll do the measurement by the time. So this is almost the 7 millimeter. So I'll mark here 7 millimeter. It would be a marking on it. कोई सुलू मार्कर तेतिया मन so around 7 millimeter so musidia yeah so I'll just mark it here so up to this down I can go because I may require around 4 to 5 millimeter maximum, not much. So just I'll hold it here. Give a nick and then I'll hold it. And now slowly I'll try to separate the conjunctiva and make it little deeper. So I'll hold it here and try to expose as much as possible. Now I'll try to cut as much as this one. Now, as per the marking, I'll try to do this separate.
So we cannot, can you just center it? Yeah.
Yes, ma'am. Is it
Yeah.
okay?
Yeah, now it is okay.
Yeah.
Oh, your microscope automatically it's moving. Why?
Yeah.
Why it's going?
Yes, now we can see.
Can you see, ma'am?
Yeah, yeah. we can
Yeah.
see.
Yes, ma'am. So I'm just separating the Mac person. So I'm just separating and so it is already separated. Actually, I was pulling this. So I have just rotated it. And so now was aerosol there. I'll try it, just dry it out. The glue to them. And so I'll try to so give me the instrument. So I'll try. No, next year. So just I'll dry. So now the different two components of the tissue glue. Now I'll use one component, any one component you can use on any surface. So I will, the adhesive one, I'll try to use. So the, which is little liquefied, is I'll try to put over the surface. Yeah. And another, so this is which I am putting duta instrument main portion. So I have put another portion on this and I flip it over. Can you see, ma'am?
Yes, yes, very well. We can see very well.
It's nicely rotated. I'll put it over this one.
Can we just move it towards your left side? Yeah.
Is it
yeah.
okay?
Yeah, perfectly all right. Now we can see it very well.
You can see, ma'am.
Yes, yes.
Yes. So now we'll try to say.
Yes. Now I think the bleeding is also a little less because the fibrin itself
Yes, ma'am.
retards the bleeding, the fibrin glue.
So can you give certificate this one? No, musibo and glue there. Yeah, give me some amount of glue. I'll try to put here. There one bundle. So I'll try to do this. So almost the surgery is that way is over, and the donor part we can leave behind as it will heal by itself. Or if you want, we can pull it and do the suture, or even with the glue also. But in my last 15 years, I never suture. It healed by itself. So
Yeah.
there is no need to do. So this is absolutely wonderful. So there is no need to do. And at the end, we can give DECA also, Genta, if you want, so to reduce the inflammation. So if you don't, we can give. But I prefer to give DECA, Gera while at the end of the surgery.
And what is your post-op regime in such cases?
My post-op regime is your antibiotic drops and ointment I give, and pepper, the FML drops, fluoromethylone drops, I taper it slowly, 4, 3, 2, 1 for a month, and one lubricating drops, this much. And
Right.
I continue it for a little longer, lubricating drops, rest I stop by a month.
Okay,
Sir.
very nice.
So
Very
I
nice.
think it's absolutely,
Yeah, the case was very, actually,
Yeah.
it was not a very easy pterygium.
yeah, madam,
It was
it's
quite a
very
difficult pterygium. but-
it is a very fleshy mask. I took to
Yeah,
show that, ma'am. Yes, ma'am.
Yeah, but it's looking now. It's looking very
now
clean.
it's looking very nice, very nice.
Yeah,
And
actually, the microscope setup, something has gone wrong, ma'am.
yeah,
That's why it was not because now. So now, hope it's. I could. If any question, ma'am.
no,
Anything?
no, not at all. You did so well, all the steps.
Yeah, ma'am.
You are very meticulous, Dr. Balmukund, whether you do
Thank you.
cataract or you do pterygium.
Thank
Yeah.
you. Thank you so much.
Very meticulous and very clean and textbook like.
Okay. Thank you, sir. Thank you, ma'am.
Thank you. Thank you very much.
Yes.
उल्टा पुल्टा माइक्रोस्कोप उल्टा पुल्टा করে থই দিছে
So, Dr. Rajesh, would you use mitomycin C in some of the cases? Where would you want to use mitomycin C?
Actually, I would not be very, I'll be a bit conservative in terms of using mitomycin C in case of pterygium.
Illumination बहुत इसका
Pterygium
लेकिन
will never use it. In
illumination
recurrent
कितना
pterygium, with very bad, fibrosis, I may use it, but in primary pterygium, never. In secondary pterygium, I mean, in a recurrent pterygium also, if fibrosis is not bad, I will
not
do cat and leave it. But if it's very bad fibrosis, then I may use it.
Okay, so Dr. Kasturi, can we have the details of this case?
Yeah, can you hear me?
Yeah, we
Yeah,
can.
very, very nice, very
I'm
clear.
taking a very challenging case. This is a very high myope post vitrectomized, and the zonules are, though if he looks down, it is under topical. Niche dekho, Tolotsa. You can see the zonules. It's showing a little bit of zonular dialysis inferiorly. Look straight, Siddha sir, like sir. So Vatsala, will you do the timeout?
Yes, it's a 35-year-old male patient, right eye to be operated. As per the biometry, his emmetropic power is 6.5 diopters.
Action length कितना है इसका?
Exit length is how much, Vatsala?
29.
The
29.
axial length is 27.74.
Okay. 28.
Maybe the myopia is high because it is a post vitrectomized.
Yeah.
And my only worry that, post vitrectomized, the AC maintenance is very difficult at times, and that to a very high myope. And second issue with this post vitrectomized, touch wood, it should not happen. And the zonules are friable and a chance of lens drop. And sometimes your surgeon also, can you see the zonules, the weak zonules?
Absolutely, we
are there?
can see that. We can see the margin of the lens.
Yes.
Post vitrectomized, I have also noted that, in many of these, zonules are slightly compromised.
Yeah, so
And the lens the glow is appearing good, but the lens is not going to be very soft. It's going to be on the harder side.
yeah, though the glow is good, it
Yeah.
will be towards the harder side. Let me start with the rexis. Purposefully, I thought that let us take a challenging case. Oh, it's very deep. Not even now it is touching. Trying to concentrate on this rexis, because as I come inferiorly, I know there's a chance that it might pull it towards the side of zonular dialysis. Want to make it a round one, so I'm not pulling it inside. I'm going outside so that there is no tag. And yes, it's almost done, the rexis.
Yeah,
And
very nicely done.
Yeah, I think you can see the axis well now.
Yeah, we can see it
yeah.
very clearly.
Centered now. As usual, I really like when the inner lip is straight and not, I appreciate when the inner lip is straight. I'll do a little bit of hydro dissection, little scared to go ahead. I don't know the status of the posterior capsule.
I think in the post vitrectomized eyes, it's always unpredictable what
Yeah,
the capsule is going to be.
but not a very dense cataract. অলপ microscope to turn কৰি দিবা নেকি? This way. অলপ little bit. Yes. Chopper নালাগে। I'm using a very interesting tip. I think you can make out what tip is this.
Yeah, balanced.
This is basically for the soft cataract and when you're a little scared of your vitreous, I mean, in a situation. This is a hybrid tip by the Elcons. This is very safe.
Okay, so the cataract was quite soft.
The cataract was soft and luckily I was using this hybrid tip.
Yeah.
Aye.
So would you like to put endocapsular ring in this case?
I don't think now, let me see, it looks very stable. Though there is zonal dialysis, but I don't see much. Even when before the operation, I had seen in the slit lamp. There was no much phacodonosis. Yeah, let me see if I see that the rexis is not centered. After taking this off, then I'll put a CTR. If the rexis is centered, then I think I will not put. Okay, now let us see how center is the rexis.
It looks quite central actually.
I feel the rexis is quite centered, but
Yeah, it's quite centered.
yeah, I don't think that I need to. But this patient, I definitely prefer a clarion. Oh, there's little cortex superior. I'll remove it out. I prefer clarion in this patient for two reasons. Because this clarion had the axial stability. Give me the lens. So this is the clarion which you can see here. This is here. First, I will put my viscoelastic. I'll finish my Provis because I'm just putting whatever viscoelastic he's giving. Then you just need to throw out this, extra piece of extension. Then see the moment you tip, can you, the moment you press here, with the carbon dioxide gas, it is just pushing. Can you see it goes on its own? Yeah. And the advantage of this, I don't know, they say clarion stands for clarity. Myope patient, I'm preferring this because I don't want to do a yak cap later, number one. Number two, they say that PCO will be less with this lens. And thirdly, they say that the axial stability is higher. So we all know that there's a little shifting of the IOL is there with either a high hyperope or a high myope. So considering the benefits and the company is claiming and showing us with the literature. So if I do a very high myope, this is the lens of my choice. Like, I'm very happy with this because it comes out so well. So I feel everything is very well centered. Yeah. And there's a little, there's a little amount of cortex which I can see just below the incision. Then I'll take it down now.
A trace kind of a thing is there.
Yeah, there's a small one.
Yeah.
Because Kasturi, you are a very quick surgeon. All your cases you do so quickly.
Yeah, everyone says that. Yeah, see one important step which I feel everyone should do is washing the lens from behind.
Yeah.
Yeah, this is very important. And then at the same time, if you want, you can wash it below. And let me see this. Oh, this is gone, I think. Wait, this, I had taken out that cortex. I
Yeah.
think you had seen when I moved the tip towards the thing.
Yeah.
So this is at the end of the surgery. The lens is well centered. So I don't think, let me form the AC. And so with this, we are almost end. I think there's one more surgery with the ingenuity. BM will be doing. And let me wash it further. Okay. Is it clear now?
Yeah,
Yeah,
yeah.
absolutely.
Absolutely centered.
Very well centered and looking very good.
Yeah, thank you so much. So
you,
now we
Dr.
are going to the last surgery. Ask them to switch on. And after that, if anyone have any question, we can take it for 5 to 10 minutes. I understand it is getting quite late.
Oh, no, it's okay.
Yeah.
Okay.
Both
But I
dunya
think,
hoise.
Kasturi, we've had such a variety of cases, blepharoplasty, which we've never done on our platform before live. So
Yeah.
this is the first time. And then we
Thank
had
you so much for this opportunity. It's a big opportunity for us, and especially like I felt very good when you have given us this offer. The consultants were so enthused about it. So there are more consultants that think, "Ma'am, I want to do this." That I go, okay, next time we'll give a chance to the rest group.
Yeah, next time definitely
Definitely.
Yeah.
we'll give the chance to the remaining ones.
Yeah. Thank you so much for this opportunity.
But what an array of cases, right from
Yeah,
to
yeah.
blepharoplasty to vitrectomy to SICS to phaco to 3
Pterygium.
Ingenuity, Constellation. I
Thank
mean, it
you.
was just
Yeah.
beautiful.
Yeah.
Thank you very much.
See, it's an opportunity for all the people who can't come to your OR and watch you there, to watch them from their own houses, comfort of their own laptops, the desktops. So I think, thank you for that. I know all this requires a huge amount of organization. I mean,
Thank
it's
you
a
very
lot
much,
of,
ma'am.
yeah, it's a
At
lot
least
of
we have-
effort.
Yeah.
Lot of effort.
Yeah. Without
I'm so
entering your OT,
happy.
we have entered.
We've entered your OT without entering.
Thank you so much. It's a big honor for us, and I should thank AIOS for giving this opportunity, especially Namrata madam. It's so sweet and kind of you. Like the moment she called me up, I thought, okay, nothing doing VR interviews. Okay, thank you very much. So we are going to the next OR.
Yes.
It's an ingenuity, right? Start karo diya, tat. Ready. Yeah, drop to the. I think খুব ভালো হয়েছে, huh? Operation excellent. Huh? খুব ভালো হয়েছে, everything went well. Okay.
So I think with the ingenuity, you need to wear these glasses so that you are able to see the three-dimensional image of the surgery. And there are various advantages of ingenuity. One is that you don't have to look into the microscope. Two is that you have to look straight ahead and it's a lot more magnified. The depth is also much more than what you see through the microscope.
And also one doesn't have to bend his neck. So that is also an advantage.
In the long run, for people who have, long lists, you don't have to bend your neck or your back. So that's advantage. But of course, you need to get used to the system.
But on kiya hai mera? On.
And you can see that Dr. Balmukund,
Yes, ma'am.
wearing once again, hello, and wearing those 3D glasses.
Light to sabo, सीधा सब और एने का बस मोटो सीधा साइड ही ये तो डाउन करो ये इतने ये तो साइड आपको लाइक बोले देखिए यस डाउन करो आपको बराबर.
I think the resolution is also a lot better with ingenuity and with heads-up system as operating microscope. We can see very clearly.
Yes, ma'am.
Yeah. There are no issues of the operating microscope. Yeah. So I think you've instilled poverty in iodine in the fornix?
Lordson na koribote? Yes.
So how long do you keep the povidone iodine, Dr. Balmukhan?
30 seconds we keep for was the ball. Was there? 30 seconds was you. So we are going to yeah.
Now, Madhusmita will do the timeout of this patient. Madhumita, tell the details.
Yeah, so our patient is a 41-year-old female who is from Guwahati only, and she came with the complaint of diminution of vision in both the eyes, more in the left eye, and it was gradual in onset, which was like 1 year back. She felt like she had diminution of vision. So the right eye visual acuity was 660, which improved to 612 on the pinhole examination, and on the left eye it was counting finger 3 meter, and it was improving up to 636 on the pinhole. So on slit lamp examination, we found that in the right eye, it was a NS1 with the early posterior subcapsular cataract. And in the left eye, it was a NS2 cataract with a central posterior subcapsular cataract. And the fundus finding were within normal limit. So we planned with the left eye first. So it was a left eye phacoemulsification with a Clarion IOL implantation. And according to the biometry findings, the IOL power came out to a 22 diopter.
Thank you so much for those details.
So, ma'am, I have started the surgery.
Yes, yes, we can see very nicely. Everything is visible.
Yes, ma'am. Was.
Am I audible also?
Yeah, you are audible, Kasturi. We can hear you. So can we just have the microscope view? I mean, just the eye view? No, the other one. Yes, perfect.
Was needle there? Was there?
Do you have any criteria that on that which cases you will do on heads up and which cases you will do under microscope?
It's not actually that it isn't decided.
It depends on the availability of the heads up.
Microscope, yeah, heads up.
And who can afford on infinity?
Infinity.
Yeah.
Very nicely, Dr. Balmukhan, we can see the way you are bending the needle.
Yes, ma'am.
And I think one thing which needs to be highlighted is the way somebody is draped. I mean, beautiful draping with all the lashes behind the drape.
Yeah.
And this is Sister Bhanu assisting Dr. BMA.
Okay.
She's
Okay.
one of the best assistant. Like all of us, we look after her, and she really drapes very well.
Very well
Only
done.
one case we could not show is a flex because our flex OT is in the other building.
Okay.
So we wanted to show a case of flex, but I thought the next time given a chance, we
Yeah,
will take
surely.
a flex.
Next
And,
time.
place it. Yeah.
Definitely next time we will
Yes.
flags from the other OT.
So your left hand, I don't think it is a Sinsky, it is some other instrument.
No, it is not Sinsky, ma'am. It is just
Spatula.
yeah,
Iris.
iris repositor.
Repository.
Okay. So you don't have to show us flex, Kasturi, Dr. Balmukhan.
Yeah.
I've done rexes just like flex rexes.
It's like a flex.
So we am going. So now I'll dip inside. So remove this some amount of viscose. So little bit of. Now behind you can see the wave has gone.
Yeah, we could see the wave being behind.
Now it nicely rotated. This one. No, this
Okay.
spot. So don't move, don't अपने सको सीधा साइड रखो. लॉर्सन न करो. Procedure 2. So first sculpting.
Procedure 2, sculpting.
So I think the sleeve is being adjusted to push
Yeah.
it a little back.
Yes, ma'am. With what key this?
And I
Upward
think
adjust.
this is the balance tip,
Yes,
Kasturi.
ma'am. Yeah, I always prefer, ma'am.
Balance tip. Even I prefer balance tip.
Yeah. This balance tip has really reduced the amount of cumulative dissipated energy that is
Very
used
true.
in any grade of cataract. So this is something which is really very good. And plus the wound burn also is negligible because there is a differential movement. There's more movement at the distal end of the tip than the proximal.
Yes.
So it is a very useful innovation that has come up from the company.
So I'm making a trenching. You can see.
A nice trench, yeah.
We can see the glow behind.
Yeah.
And now it's
Hey, comma decrease the cut. Power comma dia.
So the lens is a little funny. It is harder in the center and softer in the periphery.
yeah. That's why.
Hmm.
Very leathery.
Quadrant.
Very leathery.
Quadrant this one.
Be careful there.
Tooth there.
Decrease the thing, energy.
So Kasturi, do you have different choppers for different grades of cataract, or do you use one?
No, we use the same chopper. If it is soft, we use the Sinsky. And if it is little harder, then this is the chopper we use. This is from Epsilon, and this can pass to a very, 26 gauge.
just
The
keep
size
this
is
one.
26 gauge. So we
I'll
find
put
it very
some
useful. Like
Abhi light to
sometimes
Sabasila.
what happens with a bigger chopper, you have to increase the side port.
Yeah.
And sometimes the eyes get stuck to that. So this you passes to 26 gauge. So, and if it is a soft, only with Sinsky we do it.
So, I think the best part about Constellation is that it has various modes. It has a epinucleus mode. It has a vacuuming and polishing mode. So that really helps. Maybe not an expert surgeon who can control everything with a foot ped, but it kind of puts a brake on the surgeon who's a new one.
Mhm. And the followability of this machine is really amazing. The
Yeah.
Centurion.
Yeah.
No. So Now I'll do the cortical cleanup.
For last 1 week, Guwahati is extremely cold and it is raining.
Okay.
Okay.
No, I thought Delhi was cold.
No, no, it's too cold. And with the rain and so much of humidity, you will see most of the people are coughing now. Everyone are wearing five cardigans. All the residents and fellows will come and tell me, ma'am, I'm wearing 4 cardigans, 5 cardigans. Still, it is so cold.
Maybe Guwahati is not used to this much cold also.
Yeah, this time I think this is the highest cold I think we have, as far as I remember.
So now rest cleaning I'll do with the water jet.
Water jet. I like this water jet a lot. Huh? Dr. Balmukund, very nice. Water jet really helps you.
Those fibers, the cells that they get detached very nicely with this water jet.
Yes, central, everything is. Yeah. So I'm going to put your
Clarion again, I think.
right in this session. You can show. So to this part you have given. Remove this part. Put it this one. So
I think having to have a lens which is preloaded also is a great advantage. There is
true.
no microbial contamination
Yes,
touching the part
yes,
of the
ma'am.
lens with the ocular surface.
True. So lens well within the bag.
Yes. Very well within the bag. Again, very nicely done case.
Now we'll clean behind cortex. Okay.
Now this instrument which you're using in the left hand is probably a Lester, or because it has a ball on it.
Yes, it's a Lester.
Yeah. Yeah. So we are using list. So that if we will, if when you hit sometimes, that's why we are using.
Yes.
That is the reason. So almost it is completed.
So, ma'am, this is the end of the surgery. So
This is the
within
end
2
of-
hours, 20 minutes, we could finish the
Correct.
8 surgeries.
My God, that must be really a record.
Thank you very much for the opportunity. And
There are a whole lot of congratulatory messages
So,
all over.
and thank you, Elcon, for sponsoring all the lens.
yes. So thank you so much, Rajesh sir, Namrata ma'am, for giving us opportunity to highlight.
Thank you, Dr. Balmukand, for showing us such wonderful cases. And like I said, there were so many firsts. First time we've seen blepharoplasty, so immaculately done cases, all of them, and such variety of cases. I don't think we've had so many number of cases with such variety at any Surginar. So congratulations to all of you. And I know it's a huge amount of effort. So thank you so much for doing this on a Saturday evening, which I'm sure all the staff who are there in the OR, must have taken an extra time here to be there, to be doing their OR in the evening. The technicians, the nursing staff, everybody, all the residents who've been arranging the cases. So actually, we need to thank you for your contributions, for your effort, and for your time, and for those excellent surgeries that were done today.
Thank you, ma'am. Thank you so much.
Thank you so much.
Yeah.
Thank you.
Thank you.
Rajesh sir.
Wonderful spectrum of surgeries, I would say. Extraocular, blade, pterygium, cataract, everything. So it was a treat to watch and a wonderful demonstration. Thank you very much.
Thank you, sir.
Thank you very much.
Thank you very much.
Thank you, Kasturi. We would like to thank Alcon, our sponsors for this event, audiovisual team from Mr. Ravi Grover, who helped to coordinate this transmission, which was again very good. Every single vessel, every single fiber could be seen and very well demonstrated. It was a treat to watch. Absolutely, Kasturi. We felt it should go on and on, but it was really nice. One never gets tired of seeing live surgeries. So it was really nice. We hope to have you yet again on another, occasion for a live surgery show. So thank you.
Definitely.
Thank you.
Thank you so much.
Thank you.
And today happens to be a Saraswati Puja here.
Yeah.
That is,
Vasant Panchami.
yeah.
And
So
we
on this
probably-
auspicious day, we could have the first Surginar with AIOS. It's a great
Yes.
day for us also.
Thank you. Thank you. And you
madam.
can play
Thank you,
your,
Dr. Rajesh.
Kasturi, you can play your, ask the admin to play your video of Shankar.
I'll tell them.
yeah.
I'll tell them now.
Sure, sure.
पंकज, हमारा जो
I think it was a very beautiful, nice video of their institution, which was being played just before we joined. So
Okay.
we could, show that so that one knows the values behind the way the institution it was established and the way it is working. So admin, do you have the video, please? Can you play it? The video which was being played right in the beginning of the Surginar.
तुम्हारा क्या तान कोई बाय बाय दिया आपके पास से वीडियो है ना, ये प्ले कर दीजिए। पहला जो सब प्ले जो प्ले किया था। Yes, ma'am. He's playing it.
Yeah.
Yeah. Full screen कर दीजिए with the sound.
Divine wish and altruistic desire of their holinesses, the Shankaracharyas of Sri Kanchi Kamakoti Pitham, Kanchipuram, untiring human effort, sustained public support, and the need of people in general, coalesced to give shape to a socially relevant service institution. On 14th October 1994, Sri Shankar Deva Netralaya, named after the great Vaishnavite saint of Assam, Srimanta Shankar Dev, came into existence. Dedication, teamwork, discipline, and an ethical approach to work, along with the continued support of public, private, corporate, and government institutions and people from all walks of life, has been instrumental in the sustained growth of this institution. On 24th of November 1995, the then Prime Minister late P.V. Narasimha Rao dedicated the services of the centre to the nation. The subsequent visit of the then President, late K.R. Narayanan, further strengthened this status. An endeavour which started off as an eye care centre for the region with just 5 patients, has today been transformed into a world-class eye hospital with state-of-the-art facilities under the able management of Sri Kanchi Shankar Health. The institution, a center of excellence, on his visit on 21st November 2004. The new hospital building houses super specialty clinics which offer services such as cataract and refractive surgery, uvea and medical retina, contact lens and low vision aids, orbit and oculoplasty, medical photography, retina and vitreous surgery, glaucoma, altruistic desire of their holinesses, the Shankaracharyas of Sri Kanchi Kamakoti Peetham, Kanchipuram, untiring human effort, sustained public support, and the need of people in general, coalesced to give shape to a social
Technical issue, I think he's solving it out.
Okay.
Ma'am, just 2 minutes. It will be done.
Okay. Okay.
Okay.
divine wish and altruistic desire of their holinesses, the Shankaracharyas of Sri Kanchi Kamakoti Peetham, Kanchipuram, untiring human effort, sustained public support, and the need of people in general, coalesced to give shape to a socially relevant service institution. On 14th October 1994, Sri Shankar Deva Netralaya, named after the great Vaishnavite saint of Assam, Srimanta Shankar Dev, came into existence. Dedication, teamwork, discipline, and an ethical approach to work, along with the continued support of public, private, corporate, and government institutions and people from all walks of life, has been instrumental in the sustained growth of this institution. On 24th of November 1995, the then Prime Minister late P.V. Narasimha Rao dedicated the services of the centre to the nation. The subsequent visit of the then President, late K.R. Narayanan, further strengthened this status. An endeavour which started off as an eye care centre for the region with just 5 patients, has today been transformed into a world-class eye hospital with state-of-the-art facilities under the able management of Sri Kanchi Shankara Health and Educational Foundation. As demand for its services grew manifold, the institution moved into its new premises on 21st October 2001. The Honourable Prime Minister, Dr. Manmohan Singh, declared the institution a centre of excellence on his visit on 21st November 2004.
This renowned institution as a centre of excellence.
The new hospital building houses super specialty clinics which offer services such as cataract and refractive surgery, uvea and medical retina, contact lens and low vision aids, orbit and oculoplasty, medical photography, retina and vitreous surgery, glaucoma, squint and orthoptics, Botox and aesthetics, and the most technically advanced operation theatre and ICU. The Eye Bank, which was flagged off in 1997 in collaboration with the Indian Eye Bank Association, is the first accredited corneal transplant centre of the Northeast. In collaboration with Orbis International, Sri Shankar Deva Netralaya has been able to set up an exclusive pediatric outpatient department. The hospital today is able to serve with more precision and perfection, offering state-of-the-art outpatient department, inpatient wards, along with a highly efficient administrative machinery. Sri Shankar Deva Netralaya has also emerged as a prestigious centre for postgraduate education in ophthalmology and also for training of paramedicals. It has been the first in the Northeast to set up a wet lab for imparting training on various complex surgical procedures. The institution ensures a busy academic calendar dotted with continued medical education programs, conferences, seminars, and workshops, both national as well as international. To reach out to the rural populace, the institution launched a structured community service program. The program provides eye screening of patients at the doorsteps, two-way transportation of patients from the eye screening camps to the base hospital at no cost to them. It has assisted several hospitals in the development of quality human and technical resources in the northeastern states of Tripura and Meghalaya, as well as in the state of Haryana. After completion of its dedicated service to the nation for over a decade, the Nethralaya would like to redeem its solemn pledge to continue its humble contribution towards world-class eye care, community service, development of human resource, ophthalmic education and research, and comprehensive eye care to all.
So thank you so much. Thank you so much, Kasturi, once again, for again that peep into that through that video. We could, watch everything about your institute, and thank you again very much. Thank you, the entire team over there. I think you all deserve a standing ovation for what you have done today, and thank you so much. Rajesh.
Okay, thank you very much. It was a wonderful teamwork and very good surgeries demonstrated. Thank you very much.
Thank you.
Thank you.